Welcome to another MCQ quiz session. Today, we'll dive into a quiz on anti-gout medications, a vital group of drugs for treating gout. The quiz consists of 10 scenario-based multiple-choice questions aimed at sharpening your grasp of this topic. Each question comes with 5 possible answers, and the correct choice will be explained in detail for better understanding. To explore the concepts more thoroughly, check out the companion review video linked in the description. So, let's begin. Question 1. Mr. Harrison, a 56-year-old male with a history of hypertension, presents with acute pain and swelling in his right first metatarsophalangeal joint. He has chronic renal insufficiency with an eGFR of 28 milliliters per minute per 1.73 square meters, and he is on enalapril for blood pressure control. The physician considers starting therapy for acute gout but wants to avoid complications. Which of the following medications is contraindicated in this patient due to his renal status? Option A, indomethacin. Option B, colchicine. Option C, prednisone. Option D, allopurinol. Option E, febuxostat. The correct answer is option B, colchicine. The explanation is that colchicine is contraindicated in patients with severe renal impairment due to the risk of accumulation and toxicity. In renal insufficiency, colchicine clearance is reduced, leading to increased risk of bone marrow suppression, neuromyopathy, and gastrointestinal toxicity. Alternatives such as corticosteroids are safer in this patient population for acute flare management. NSAIDs also carry risk but can be considered with caution, whereas allopurinol and febuxostat are primarily for long-term urate lowering, not acute therapy. Question 2. Mrs. Johnson, a 42-year-old woman with recurrent gout, has been prescribed allopurinol. She also takes azathioprine following renal transplantation. The physician is concerned about a serious drug interaction that may increase toxicity. Which of the following best describes the mechanism of this interaction? Option A, allopurinol increases metabolism of azathioprine by CYP3A4. Option B, allopurinol decreases conversion of azathioprine to 6-mercaptopurine. Option C, allopurinol inhibits xanthine oxidase, reducing azathioprine metabolism. Option D, allopurinol displaces azathioprine from plasma proteins. Option E, allopurinol enhances renal clearance of azathioprine. The correct answer is option C, allopurinol inhibits xanthine oxidase, reducing azathioprine metabolism. The explanation is that azathioprine is metabolized into 6-mercaptopurine, which is further broken down by xanthine oxidase. Allopurinol inhibits this enzyme, leading to reduced metabolism and toxic accumulation of 6-mercaptopurine. This can result in severe myelosuppression and life-threatening pancytopenia. Therefore, concurrent use requires either extreme caution or significant dose reduction of azathioprine. Question 3. Mr. Thompson, a 65-year-old male with gout and ischemic heart disease, presents with frequent acute flares. He has been receiving colchicine for prophylaxis, but now reports diarrhea and myopathy. He is also on atorvastatin for lipid control. Which of the following mechanisms best explains his toxicity? Option A, enhanced P-glycoprotein-mediated clearance of colchicine. Option B, CYP3A4-mediated inhibition increasing colchicine plasma levels. Option C, colchicine directly potentiating statin muscle toxicity. Option D, increased renal excretion of colchicine due to statins. Option E, impaired colchicine absorption in the gut. The correct answer is option B, CYP3A4-mediated inhibition increasing colchicine plasma levels. The explanation is that colchicine is metabolized by CYP3A4 and is also a substrate for P-glycoprotein. Statins, especially atorvastatin, can inhibit these pathways, leading to increased colchicine concentrations. The result is heightened risk of gastrointestinal side effects and neuromuscular toxicity such as myopathy. The drug-drug interaction explains why colchicine toxicity occurs more often in patients also receiving statins. Question 4. Mr. Anderson, a 48-year-old man with chronic tophaceous gout, is prescribed urate-lowering therapy. The following statements about allopurinol are correct except Option A, it reduces uric acid formation by inhibiting xanthine oxidase. Option B, it can cause severe hypersensitivity reactions in HLA-B*58:01 carriers. Option C, it requires dose adjustment in chronic kidney disease. Option D, it is contraindicated in patients with peptic ulcer disease. Option E, it can precipitate acute gout during initiation. The correct answer is option D. It is contraindicated in patients with peptic ulcer disease. The explanation is that allopurinol is not contraindicated in peptic ulcer disease, and in fact, gastrointestinal irritation is not its major limitation. The major safety concern is severe hypersensitivity syndrome, especially in those with the HLA-B*58:01 allele. DOS reduction is required in patients with renal impairment to avoid toxicity. Additionally, urate-lowering therapy can trigger acute flares initially, which is why prophylaxis with colchicine or NSAIDs is often recommended. Question 5. Mrs. Baker, a 38-year-old woman, has recurrent gout attacks during pregnancy. NSAIDs and xanthine oxidase inhibitors are avoided. Which of the following drugs is most appropriate for urate-lowering therapy in her case? Option A, colchicine. Option B, allopurinol. Option C, febuxostat. Option D, probenecid. Option E, pegloticase. The correct answer is option D, probenecid. The explanation is that probenecid is considered the safest urate-lowering option in pregnancy because it promotes renal excretion of uric acid without teratogenic risk. Colchicine, allopurinol, and febuxostat are generally avoided due to insufficient safety data or potential fetal harm. Pegloticase is also contraindicated because it is not studied in pregnancy and carries a high risk of hypersensitivity. Therefore, uricosuric therapy with probenecid remains the most appropriate choice for pregnant women with recurrent gout. Question 6. Mr. Wilson, a 59-year-old patient with chronic gout, has been switched to febuxostat after developing a severe rash with allopurinol. Regarding febuxostat, all of the following are correct except Option A, it selectively inhibits nonpurine xanthine oxidase. Option B, it can be used safely in moderate renal impairment. Option C, it is associated with increased cardiovascular mortality. Option D, it requires dose adjustment in mild hepatic impairment. Option E, it is contraindicated with uricosuric agents. The correct answer is option E, it is contraindicated with uricosuric agents. The explanation is that febuxostat can be used in combination with uricosuric agents when additional urate lowering is required. It works as a non-purine selective xanthine oxidase inhibitor, reducing uric acid production. Febuxostat is safe in moderate renal impairment and requires dose adjustment in hepatic impairment. However, its use is limited by an increased risk of cardiovascular mortality, making this an important clinical consideration. Question 7. Mrs. Collins, a 70-year-old with chronic heart failure and stage 3 chronic kidney disease, presents with frequent gout attacks. Her physician considers urate-lowering therapy. Which of the following agents is least appropriate in this patient? Option A, allopurinol. Option B, febuxostat. Option C, probenecid. Option D, colchicine. Option E, prednisone. The correct answer is option C, probenecid. The explanation is that probenecid is ineffective and potentially harmful in patients with chronic kidney disease because it relies on renal function to increase uric acid excretion. In such patients, uricosuric drugs do not adequately lower urate and may increase the risk of nephrolithiasis.
allopurinol and febuxostat can be used with dose adjustments, while colchicine and corticosteroids are safe for acute management.
Therefore, probenecid is the least appropriate choice for this patient.
Question 8.
Mr. Robinson, a 50-year-old man with refractory gout, has received pegloticase. After infusion, he develops shortness of breath, hypotension, and urticaria.
These findings suggest an infusion reaction. Which of the following mechanisms best explains this reaction? Option A, immune complex deposition causing type 3 hypersensitivity. Option B, IgE-mediated mast cell degranulation, type I hypersensitivity.
Option C, complement activation by uric acid crystals.
Option D, direct toxicity of pegloticase to endothelium. Option E, cytokine release syndrome from T-cell activation. The correct answer is option B, IgE-mediated mast cell degranulation, type I hypersensitivity. The explanation is that infusion reactions with pegloticase are often immediate hypersensitivity reactions mediated by IgE. These reactions involve mast cell degranulation, leading to symptoms such as urticaria, bronchospasm, and hypotension. They are similar to anaphylaxis and require close monitoring during administration. Pre-medication and discontinuation after severe reactions are critical safety measures. Question 9. Mr. Edwards, a 61-year-old with chronic gout, is being considered for urate-lowering therapy.
Compare the following drugs used for chronic gout management.
Which drug lowers serum uric acid by increasing renal excretion rather than inhibiting production? Option A, allopurinol. Option B, febuxostat. Option C, probenecid. Option D, pegloticase. Option E, colchicine.
The correct answer is option C, probenecid. The explanation is that probenecid is a uricosuric drug that increases renal excretion of uric acid by blocking reabsorption in the proximal tubule.
In contrast, allopurinol and febuxostat inhibit xanthine oxidase, lowering uric acid production. Pegloticase works differently by breaking down uric acid into allantoin, and colchicine only manages inflammation during acute attacks.
This makes probenecid unique among these agents as an excretion enhancer.
Question 10. Mrs. Parker, a 46-year-old woman with chronic gout, is on losartan for hypertension and low-dose aspirin for cardiovascular prevention. The physician is considering adjunct uricosuric therapy. Which of the following drugs would be least effective due to interaction with aspirin? Option A, probenecid. Option B, sulfenpyrazone. Option C, lesinuride. Option D, losartan. Option E, allopurinol.
The correct answer is option A, probenecid. The explanation is that aspirin, even at low doses, interferes with the uricosuric effect of probenecid, making it much less effective.
Sulfenpyrazone and lesinuride can still be used with aspirin, though careful monitoring may be needed. Losartan itself has mild uricosuric properties and is not hindered by aspirin use.
Allopurinol, which inhibits uric acid production, is also unaffected by aspirin, making probenecid the least effective option in this clinical setting.
That wraps up our revision on anti-gout medication.
I hope you found this quiz session engaging and informative. To deepen your knowledge further, consider reading resources like Katzung and Trevor's Clinical Pharmacology, Rang and Dale's Pharmacology, and the British National Formulary, BNF. These references will solidify your understanding and enhance your preparation.